I look like such an old lady now.
Kia ora.
Amazing.
Kia ora. Welcome to day 2 of the COVID-19 Masterclass. I'm Jackie Haddingham, manager of the Otago Global Health Institute, OGHI for short. Just a reminder that the Masterclass webinars are being recorded and will be available on the OGHI website later. We're also live streaming through the OGHI Facebook page. During the webinars, each speaker will deliver their presentation and you can ask questions at any time through the Q&A function at the bottom of your screen. After the presentation, I'll read the questions aloud for the speaker to reply. We have quite a tight schedule for our webinars, so if we're not able to get to all the questions during the session, we'll ask our speakers to provide written responses and we'll post those also on the OGHI website. Our first speaker this morning, Dr. Noelyn Hung, my apologies, is an anatomical pathologist with subspecialist interest in perinatal pathology. Her topic is the performance and pathological findings of COVID-19 positive autopsy. Noelyn.
Thank you. Thank you, Jackie. Thank you for that nice introduction. I've only got 30 minutes, so I won't be doing a lot of background work. I just want to give you as much as I think we know about COVID-19 from autopsy studies. Please feel free to ask questions afterwards, though, if I've missed anything out. So I'm from the Department of Pathology. I'm a bit of a rare breed now. Anatomic pathologists are sort of dying out as we get older, and younger ones aren't being trained anymore. But by the same token, autopsy rates are also decreasing, so maybe our skills are not that needed anymore. But my first slide is a summary of all the reports I can find of autopsy in the literature. And some of these are still in preprint form. They're not even published, and I apologize in advance if I've missed anything out. But the first few cases were reported in February of this year, and then a few more in March, and now by the end of May we have about 95 cases reported, which isn't a lot when you consider that there are 500,000 people who have died, and that the whole of Western medicine really has been based on clinico-pathological correlation between what's found at autopsy and what is found from clinical symptoms and signs and studies during life. The biggest study is now this Italian one that came out at the end of May, looking at lung autopsies in particular, very little on the rest of the body. And in fact, some of these autopsy cases are only core biopsies taken from the lung at death. And my own philosophy is that we, as a profession, should be right in here, getting as many answers as we can for everyone. But I know there's been a lot of reluctance about perhaps contacting COVID-19 while we're doing the autopsy. It is an invasive procedure, no doubt. But our own experience here, we used universal precautions in our own facility, and perhaps the only extra thing we did was to keep the number of people involved down to the absolute limit, and we divided our mortuary in half, and we had technical staff on one side, I was performing the autopsy on the other, and we tried to keep things as clear and low personnel involved as possible. Subsequently, none of us have contacted COVID-19, by the way. But anyway, this is what my talk is based on, my own experience with a COVID-19 case and with these cases published in the literature. I will dive quite quickly into the pathology, and I apologize in advance if some of you aren't used to looking at well, what I call pretty pictures of disease, but I'll try and guide you through them as much as I can. So the talk will cover the pulmonary findings, obviously. They're some of the most important, and this primarily involves diffuse alveolar damage, which is a lesion that pathologists have known about, and of course clinical people too have known about for a long time. In fact, it's sort of a blast from the past for me, because as a subspecialized perinatal pathologist, this was the lesion that was found in premature babies and led them on to bronchopulmonary dysplasia. Thankfully, we don't see that very often now. So it's a lesion we're familiar with. It has 3 stages, and I'll show you some photos of those: the acute and organizing, and eventually the end stage, which was the bronchopulmonary dysplasia that caused so many pulmonary problems in these premature babies. This newer finding in terms of COVID-19 at least, which is thrombosis, and then some of the smaller findings of acute bronchopneumonia and bronchiolitis obliterans. I'll mention some of these other organs and what we found in there. What I won't be talking about is the brain findings, because as far as I can tell, no one's actually looked inside a brain at autopsy of a COVID-19 positive patient. And there are good reasons for that, and the reason why we ourselves didn't look in, and that is that there's quite a lot of aerosol generated with the sores going through the cranium, and I think we decided that was just one step too far. Clinically though, there have been some reports of infarction type problems developing, and I think we can link that back to the thrombosis. And finally, what I'm not talking about is Kawasaki-Like Syndrome. This is the pediatric symptoms and signs that have been found in association with COVID-19. To my delight, it probably means that we have maybe a reason for Kawasaki disease that we've never had before. Maybe it is a viral coronavirus type lesion, but I've seen no autopsy reports about it, and so I won't address it in this talk. So this is what the clinical people are used to seeing now from their CT and NMR scans. A very patchy process through the lungs of these opacities, which are the disease process. You can see it's very patchy, and in fact our term diffuse is probably not a good term in that respect, because it is patchy and it's not diffusely through the lungs of a lot of people. If we were to look at this just on a histological section or histopathological section, so pathologists spend a lot of time looking down the microscope in the dark, they would say, but we're looking at these actual sections of tissue where you can see the lung alveolar septi here. This is not with any magnification apart from putting it up on the screen, and it's an H&E section, which is why it's pink and a bit of purple. But you can see that there are a lot of normal areas here, and then these filled in areas that are the diseased areas, and this correlates with the CT findings in particular. I'll come back to this red thing in a minute. So that's sort of the low power look. This is probably the very first stages that we understand are happening in COVID-19, and the reason why we're calling it diffuse alveolar damage. I may say that diffuse alveolar damage is seen with a lot of causes, not just a lot of etiologies, not just COVID-19, and it results in the ARDS, the acute respiratory distress syndrome, in a lot of cases. So this is one of the first stages. These are the alveolar septi sort of collapsed. Autopsy pathologists are used to seeing this because it's part of the degeneration that happens quite quickly after death. And these spaces here where they should be filled with air, like here, are filled with a fluid now. And as we understand it, there is an insult to probably both the endothelium that is in the capillaries in these alveolar septi, and the lining cells of the alveoli themselves, the type 1 pneumocytes. And I think every cause of diffuse alveolar damage may have a slightly different emphasis, but both of those cells are involved, and I think it's a good thing to think about the alveolar septum as being this complex of an interstitial space that's got maybe a few fibroblasts in it, connective tissue type cells, capillaries running through it lined by endothelial cells, and the alveolar septum with a basement membrane, and then the type 1 pneumocytes predominantly lining there. And both the endothelial cells and the pneumocytes seem to be damaged in a way that allows this fluid to leak out of the capillaries and into the alveolar spaces. Along with this comes some congestion, which I'll show you on our next slide. So this is a postmortem photomicrograph as well, and it's showing the hyaline membranes, which we believe develop from that fluid that's leaked into the alveolar septum. Maybe a bit of air gets in there, it sort of pushes it to the side, and we have widening of that alveolar septal complex by this proteinaceous and cellular debris, which gets pushed up along the alveolar septi. You can see them here. We call them hyaline because they look sort of glassy and pink. There's no cellular structure to them as such. And then in the background, these capillary septi are dilated and congested. That's part of probably what leads to that exudation, and this is often called the exudative phase. And then in the background too, you can see some nuclei here. These are predominantly lymphocytes, maybe the odd neutrophil. And at this stage, we don't have any real widening of the alveolar septi, although that's starting to occur here. And there's probably even some influx now of some connective tissue cells, fibroblast cells, type cells, which are the start of healing, probably from day 2 to 3 onwards. It's nothing new, that's what healing's all about, and typical of diffuse alveolar damage. So this was our case in some areas, had this early stages still of diffuse alveolar damage. So as time progresses, we know that the hyaline membranes may be cleared away a little bit more. This is a case, one of those early ones that was reported. They were particularly interested in the hyaline membranes. You can see there's a few lining these alveolar septi. There's a good one in particular. And a few inflammatory cells scattered through here. Perhaps some alveolar macrophages in the middle here. We often see these are resident macrophages of the alveolar septic, alveolar spaces. They seem to get a bit more intense as diffuse alveolar damage progresses. And in this paper, they're looking for any effects of the virus itself. So viruses have a morphological effect on tissue cells, and we can often diagnose that virus because of the morphological effect, because it's a typical effect. In the case of COVID-19, I don't think anyone's definitively shown a cytopathic effect in terms of inclusions, but there's certainly quite a lot of pleomorphism and sort of reactive changes from the alveolar macrophages and probably the type 2 pneumocytes that are now proliferating as part of that healing response. And we're getting from the exudative phase into the more proliferative phase of diffuse alveolar damage. This is another photo from from the same group, ZOO, one of their early publications, again looking for that viral cytopathy and showing the amount of material in the alveolar septi and inflammatory cells. There's a few hyaline membranes remaining down the bottom right there. This is our case again, going back to the more opaque areas, the more areas that don't have a lot of aeration to them. And we can see now we've got more alveolar macrophages in here, we've got more type 2 pneumocyte hyperplasia and more inflammatory infiltration of the lymphocyte type. This is a vessel that's been thrombosed. I'll come back to that in a minute. So these are some of the special investigations that we can do to highlight and confirm the findings that we identify morphologically. This is an H&E. There's an alveolar space here that's filled with macrophages. There are type 2 pneumocytes proliferating along this alveolar septum. They're the repair cells, if you like. And they're highlighted here by a keratin stain, which is typical for epithelial cells. And what it does show by its negative staining is the widening now of the alveolar septi. So you can see how wide this diffusion space is becoming. It's hard to pick it out in here, but there's actually an alveolar septum that goes from, say, these lining cells here right across to this side now, and there are some congested capillaries. So the whole diffusion distance has increased enormously, even if we're getting lots of air into these alveolar spaces. They seem to be filled up with cells now. So this is an immunohistochemical stain called a CAM 5.2, just a pan-keratin, and shows up those lining cells nicely. This is another one of those cells, immunohistochemical stains, that brings up surfactant-producing cells. So this is called TTF1. And it shows the proliferation of these repair-type cells, type 2 pneumocytes, producing more surfactant and lining the alveolar septi. And then this is a CD68. Normally I don't like CD68s because it's a bit of a messy stain, but it highlights, in this case in particular, the alveolar macrophages. So you can see how many alveolar macrophages now are filling those alveolar spaces where there should be air. So we're now into the proliferative stage of diffuse alveolar damage, and this stage correlates, we believe, with the stage now of clinical deterioration where they're starting to require oxygen and ventilation support. In terms of the immune response in this lesion, this is from our case, which we saw quite a few lymphocytic aggregates, not a huge number, but certainly more than you would expect in a normal lung. This is just the H&E showing all these dot-like lymphocytes infiltrating. I can't tell you whether they're B or T cells at this stage, and that's why I do immunohistochemistry. This is a CD20 antibody that picks up the B cells. You can see there's quite a few B cells. This is in a similar area, just further cut into the tissue. And then this is a CD3, which is, or CD4, which is, I beg your pardon, this is CD4, this is CD8. So this is highlighting the T cells. Have I got that right? Yes, I have. So this is the CD4 highlighting the T cells, and this is the CD8 T cells. The rest of the cells in here are B cells, would be CD20, and there weren't actually too many of those. They were mostly T cells in these aggregates. Now, one other stain that I haven't seen used in the literature yet is a CD138, and this antibody picks up plasma cells, and I was interested to know whether or not plasma cells were producing a lot of antibody at the time of this patient's death, and really there were only a few plasma cells scattered through. The CD138 has another name, which is syndecan-1, which is an interesting cytokine expressed on some of the pneumocytes, and you can see the cytoplasmic and membrane staining on some of these type 2 pneumocytes up here. It's a much more diffuse, sort of lighter staining than on plasma cells. But whether or not that's pro-inflammatory or anti-inflammatory at that stage, I can't tell you. I can just tell you it's there. Oops, right. So if I can go back to, whoopsie, sorry, I've gone too fast. If I can go back to this initial low power sort of view of the lung tissue that I showed you, I pointed out that there was this big red thing. This is a thrombus sitting within a small artery of the lung. You can see it's occluding the artery, and I think that is why this person died. Quite often with diffuse alveolar damage, we can find patients who have thrombosis associated with it. It's not uncommon, but I think it took the clinical community at least a while to recognize this was happening. I think CT scans may have missed a lot of them because they're in such small vessels, but certainly there's also cases where we've had big pulmonary emboli develop in a few cases as well. So there seems to be a hypercoagulability problem in these COVID-19 cases. From the literature, I'd say at least a third to even a half of patients who have died have had thrombosis in some place, most typically the lungs, as we saw in our case. So this is a gross photo looking at the lungs in our case. This is the pulmonary hilum, which in fact is showing this is a pulmonary lymph node. Our patient was a smoker, so there's lots of anthracotic pigment in there. The airways have some mucoid material in them, which is typically seen and in the diffuse alveolar damage case, and particularly in COVID-19. But there was no pulmonary thrombosis. This is an artery here that looked like it was a deep vein thrombosis that had resulted in a pulmonary embolus. The emboli that we saw, or at least the thrombosis that we saw, was typically just diffusely throughout all the lung small vessels. So this is just cut section. There's a thrombus sitting in a small vessel there, one there, one there. In fact, all these yellow arrows are pointing to just massive diffuse thromboses through this lung. And I think that's why this person died. He also died with no systolic pumping activity from the heart, which is typical of a massive thrombosis type picture in the lungs. When we look at it histopathologically, this is the H&E section. This is in one of the more normal looking areas. We've got lots of air coming into here, but you can see the vascular space is blocked now by the thromboses in here, and these are special stains, just confirming that this is indeed a thrombosis and not just post-mortem coagulation in vessels. Now we had an area which had a sort of an acute pneumonia. These are neutrophils. Was just in one small area, but I understand that other cases have also found a small area of bronchopneumonia type picture. What this means overall, I'm not sure, just that it's there and may have contributed to his death in terms of a sepsis. Some people are reporting a little bit of bronchiolitis obliterans. This is also an old lesion where the old lesion in terms of what pathologists know about, where the alveolar space is filled by sort of granulation tissue which slowly organises and resolves with time, and indicative of an old pneumonia there. One report has talked about what I would call corpora amylaceae, little lumpy bits of acellular material in the lungs. I think this is a non-specific finding. I've seen it in other lungs. Don't think it has anything much to do with COVID-19. So that's the lung pathology. In the last 5 minutes, which I am allowed, right? I just wanted to briefly touch on the other organs because, at least with our autopsy experience, which is, I might say, probably the highest in the world, considering New Zealand's only had 22 cases and we've managed to autopsy 1, compared to the rest of the world with maybe 100 cases and 500,000 deaths. If you look at the Ace2 receptor, which is the receptor, as I understand it, for this virus to get into tissue, you can see the concentrations actually are really high in the gut, colon, duodenum, coming down to the kidney, testis, and the lung is way down here in terms of its Ace2 receptors. And so I went through all the other tissues looking to see if there was any effect of, any viral effect in these other tissues. The heart, there have been some clinical findings, and in our case, we certainly didn't find anything, maybe a bit of lipofushkin, which is indicative of 70 years and being 70 years old. We found some steatosis. This is fatty change in the liver, not particularly prominent and certainly non-specific. In the kidneys, we couldn't find any thrombosis and certainly no evidence of a glomerulonephropathy, although there is one autopsy series of core biopsies from the kidney where they talk about a lot of proximal tubule changes. Even looking at their pictures, I might suggest that that's autopsy change, because as people get old, degenerate after death, the proximal tubule is one of the first to show degenerative changes. So I'm not sure I believe those are COVID-19 associated effects, although that's where the virus has been most consistently reported. Other people have talked about inflammation in the heart. This is a pericardium with some lymphocytic infiltration, some vacuolar changes reported in one heart, and also the same steatosis type changes in the liver reported. And they did think they found a little bit of at least congested capillaries in the kidney. The other case in this paper had one patient with an extremely large heart, 1,000 grams, a kilo. That's a very heavy heart, and I would suggest that's a cardiomyopathy in its own right. And they looked at these sort of changes in the heart, a little bit of inflammation. And then in the testes, they found thromboses. Here's another case where they would have noticed that the white matter pulp of the spleen looks reduced. Now, that's a pretty subjective finding, but interesting in terms of the immune system. In our case, at least, we looked at bone marrow, lymph nodes. We couldn't identify any abnormalities there. And when I say we, I mean, this case has also been reviewed, particularly with my colleague, Len Wakefield. We looked at pancreas, thyroid, parathyroid, GI tract, despite the high levels of Ace2 receptors, and could find no lesions. And in fact, our gut was actually well preserved, considering it was an autopsy specimen. Adrenals, skeletal muscle also, and the brain, as I say, we didn't examine the brain, but clinically there could be some infarcts from thrombosis type events happening. So this is a summary of what I see in COVID-19 autopsies. The diffuse alveolar damage, which manifests clinically at least as an ARDS in the cases particularly that die. There does seem to be a thrombosis or hypercoagulability happening, and this may be disseminated or focal. Correlates well with the D-dimer levels reported clinically and their prognostic significance. In the skin, there's been sort of a rash reported that probably relates to this, and in large vessels at least, possibly the brain, maybe the kidney. There is one report of prostate thrombosis occurring, and the case I've just shown you with testis thrombosis. Perhaps there's a cardiac pathology happening that's a myocarditis. We did do troponin T levels in our case, and they were elevated, not remarkably, but at least histopathologically we didn't find any changes. And perhaps there is something happening in the spleen in terms of the white matter density. Now, I shouldn't finish the autopsy findings without mentioning that there are a lot of comorbidities in the cases that have died, and whether or not this is related to Ace2 receptors, that's fascinating in terms of the cardiovascular function. Our case certainly had some atherosclerosis in the coronary arteries, but otherwise was fairly clear of hypertension, but had chronic obstructive pulmonary disease, and I should have mentioned that in here. That's one missing. In fact, I might take the liberty of fixing that in my final slide that's put up, is adding in the chronic obstructive pulmonary disease. So I might stop there. That's really as much as I think I should speak to, and I'll be very happy to answer any questions that I can.
Thank you, Noelyn. I'm a little bit concerned that we may have a technical problem here because I haven't actually received any questions that have come through. So either everyone is digesting and absorbing what you've said and thinking about what they may comment, or we could have a small technical problem here. I did get one comment that came through just wanting me to confirm the length of the session. Today's webinar does go until 1:30, just to confirm that. And okay, and I've had someone who's done a testing question, so yeah, they are coming through. But Noelyn, I think you blew them away.
No, dear. I apologise in advance. Feel free to email me if it's confused you.
Well, if there's anything else, Noelyn, that you may want to go through in a little bit more detail, because I know before we started, you did say you had quite a lot of slides and you were worried you may go over time.
Yes, I was worried that I'd spend too much time speaking to these slides.
So there may be time to go into something in more detail if you like.
I guess the main thing I wanted to educate everyone about was this diffuse alveolar damage in the lungs. This does seem to be one of the critical factors leading to death in COVID-19. And I think understanding the relationship between these Ace2 receptors, virus entry, hypertension, cardiovascular disease would be an amazing advance for researchers to look into. I must say that in February I went off my own Ace inhibitor, anticipating that I might have to do a COVID-19 case, and knowing that hypertensives were highly featured in the death rate. I've since gone back on it because I've relaxed now. I don't know if anybody knows about the Ace2 receptor levels, but I understand that taking an inhibitor leads to upregulation of the Ace2 receptors, especially in the lung, and whether or not that makes people more susceptible to more viral load, I don't know. I'd be fascinated to learn about this aspect of COVID-19.
Questions are coming through thick and fast now. I've had one from one of our attendees in the room asking whether there are any therapies that could perhaps be pursued based on your pathological findings.
Yes, so the ACE inhibitors for a start, whether or not they play a role in this diffuse alveolar damage. I don't think we understand a lot about the angiotensin converting enzyme system in the lung. Certainly it's advanced a long way since I was at medical school. But just understanding what's happening to the ACE2 receptors in these diffuse alveolar damage cases, I think would be interesting. I imagine I honestly don't know, I shouldn't speculate. I love coming up with theories, but of course they're only theories. But I've stopped on this slide. I should really stop on, actually, maybe one of these slides here. Because the other aspect too is what's causing the thrombosis. I don't think it's an antibody-mediated hypercoagulability because I just can't find a lot of plasma cells there. But is it an enzyme-mediated plasminogen, perhaps mediated? hypercoagulability. I don't know. It'll be good to be able to address that, because I think with at least up to half of cases having a thrombotic event at the end stage, I think it's worthwhile pursuing some therapy for that.
Okay, I think we have about 30 seconds and we have 3 questions. We'll see what we can get through. First one, would you be able to make some comment on the possibility of permanent disability in survivors?
Yes, well, whether or not the bronchopulmonary dysplasia type features will end up being in these lungs is a fascinating question. I think with the repair process, there will be ongoing lung problems. Of course, we're not far enough into the COVID pandemic to understand those yet, but I think by the end of the year, perhaps we'll have some information on that.
Thank you, Noelyn, and I'm afraid we're out of time. So any questions we didn't get to, we will certainly email, and Noelyn will provide written responses.
Yeah, thank you.